Hi, good morning. I'm Matt State, Chair of the Department of Psychiatry and Behavioral Sciences at UCSF, and this is our first official grand rounds as the Department of Psychiatry and Behavioral Sciences, and the last grand rounds for this academic year. Today we have three outstanding faculty who will present on the topic of inequity and the disproportionate impact of COVID-19 on communities of color. I can't think of a more timely, more important topic for our final grand rounds of this year. We have limited time today, so I'm going to jump right in and introduce our speakers and then turn this over to Dr. Lisa Fortuna. So to start, Dr. Fortuna, MD, MPH, and MDiv, is Associate Professor of Clinical Psychiatry and Behavioral Sciences and Vice Chair of Psychiatry and Behavioral Sciences at UCSF. She's also Chief of Psychiatry at Zuckerberg San Francisco General Hospital. Dr. Fortuna is a child and adolescent psychiatrist with a strong interest in PTSD across the lifespan, in immigrant mental health, racial, ethnic, mental health services, disparities, and digital interventions research. She's an accomplished researcher who's been an investigator on multiple NIH and foundation-funded studies of Latino and immigrant mental health and integrated care. This includes serving as the PI on an NIMH-funded R01 aimed at optimizing a family navigation model for child behavioral health in primary care, and PI on a patient-centered outcomes research institute, PCORI-funded multi-site trial on childhood anxiety, comparing face-to-face versus digitally delivered cognitive behavioral therapy. I believe I got the order right, but our second speaker will be Dr. Michelle Porche. She's adjunct professor in the UCSF Department of Psychiatry and Behavioral Sciences and Associate Director of Community Outreach of the new UCSF UC Berkeley Schwab Dyslexia and Cognitive Diversity Center. In addition to being a co-investigator on the PCORI grant that I just mentioned, she's conducted studies of early and ongoing adversity on mental health and academic outcomes for children and adolescents. Throughout her career, she's focused on immigrant children and families and the impact of trauma for resettled youth refugees. Finally, Dr. Marina Tolou-Shams, PhD, is professor in residence in the Department of Psychiatry and Behavioral Sciences at UCSF, Deputy Vice Chair for Research, and Division Director of Infant, Child, and Adolescent Psychiatry at Zuckerberg San Francisco General Hospital. She leads the UCSF Juvenile Justice Behavioral Health Lab, an internationally recognized research program focused on developing and testing evidence-based mental health, substance use, and HIV risk reduction interventions for community-supervised justice-involved youth. Dr. Shams received her PhD in clinical psychology from the University of Illinois at Chicago, completed her postdoctoral clinical research training and postdoctoral research training, through Brown University Psychology Training Consortium. She's currently the principal or co-investigator on several NIH-funded trials aimed at improving behavioral health outcomes and reducing health disparities for justice-involved youth, including a specific emphasis on interventions for community-supervised justice-involved girls. Dr. Tolou-Shams and colleagues are also newly developing and testing digital health interventions that leverage the use of technology to improve access to substance use and mental health treatment for justice-involved youth and families. So with that, I would like to turn this over to Dr. Fortuna, who will be our moderator and first speaker.
Okay,
Lisa.
Thank you. Thank you. Good morning, everybody. So I am going to share my screen in a couple of seconds. Just a heads up, we changed the order a little bit. So I'm going to go first, and Dr. Tolou-Shams will go second, and Dr. Porche third. And I'm going to share my screen. Okay. So title of our presentation. Again, we're looking at the inequity and the disproportionate impact of COVID-19 on communities of color, employing a trauma-informed social justice response. And this is based on an article commentary that we recently published in Trauma Psychology Policy and Practice. Okay. And this is our disclosures of grants that will be, which work will be discussed in this presentation. And this is just I just happen to love this photo. Fronteras were made to divide, which this is right in our mission district here, where we know that we have many murals with themes about cultural issues, division, and frankly things that relate to overcoming injustices and trauma exhibited in art that we have here in the mission. So our learning objectives are, we're going to talk about, identify some of the ethnic racial healthcare inequities that were exacerbated by COVID-19, and how we might evaluate these disparities through a racial and social justice lens. And then we're going to talk a little bit about some trauma-informed solutions that we can consider, examples at least, that can happen at the provider, practice-based, and community level for thinking about how we might start addressing these disparities. So what are we talking about when we talk about disparities, which is a word we often hear? We're thinking at, when we look at that word, what we're really talking about is a higher burden of illness and injury, disability, or mortality for a population that might be related to differences in access to services or insurance coverage, as well as the quality of care once people do access care at all. It also exists within systems. So it includes things like medical bias, and it reflects, really the effects of racism within those systems and how it impacts on populations. And then we often also talk about social determinants of health. And really these are the economic stability, education, health, and healthcare, neighborhood, and environmental and community contexts that impact differentially, often in people's health and mental health. So what did we see in San Francisco? Many of you may know a bit about some of the things that, in terms of statistics and COVID-19. What we knew, at least here at the Zuckerberg San Francisco General Hospital, is that the Latinx population was disproportionately represented in our critically ill and intensive care units in regards to COVID-19 positive patients. There was an epidemiological study that is probably still underway, where almost 3,000 people tested. I mean, at least they were tested, and I know they're still looking at data. 45% of individuals tested were Latino or Latinx. 95% of those testing positive of those tested were Latinx, none were white. And there were similar patterns of disproportionate critical care and deaths in other places as well, as in New York. So if we look at the New York data of COVID-19 non-hospitalized cases, estimated non-fatal hospitalized cases, and patients known to have died, we can see, again, disproportionate representation of Black and African American in all of those categories, and then second, Hispanic and Latino in terms of cases, non-hospitalized, hospitalized non-fatal, and known to have died. So disproportionate burden of illness. One of the other things that was very significant was the loss of elders, matriarchs, and patriarchs. As I say, we're 57% of seniors over 60 are people of color, but 70% of the deaths in that age group are persons of color in the Bay Area, which is where we really think about the significant loss of an important generation and the impact on communities of losing these individuals. And we also know that another place where there was high concentrations were in the Mission, as we described, and also in the Bayview, related to significant socioeconomic disparities. Again, wealth, 5% of household wealthiest earning much more than 16 times more than the poor in these communities. And in the pandemic, poor blue-collar workers had a greater chance of falling ill. And those same communities are ones that suffer from many other injustices and disparities and social determinants, as we were describing before, including substandard housing and experiencing a lot of institutional racism. What we did find from some of the studies is that some of the risk factors for the COVID-19 infection rates were around congregate living and multiple housemates, in part, again, due to economic reasons. Sick contacts who have not been tested, structural and social determinants of health, and then also then having many people lose their jobs and ineligible for unemployment and other things that have then a superimposed impact economically. So as we're looking at some of the strategies that we're going to be talking about in a few minutes, what we know, at least if we think of a structure of how to address these issues, and we can see this from this article in Pediatrics, is that really at the, have both society and individual impacts of why some groups are more likely to experience ill health. At the individual level, we're really looking at social position, which is often determined by race and class in our society, specific exposures, and then disease or injury from those exposures, and then the social consequences of ill health. And that's what this is basically the structure that we saw with the COVID-19 pandemic. On the society level, the social position is really based on social stratification, and the social consequences of ill health further add to an individual or community social stratification. The ways that we can intervene and influence these things are really trying to work on decreasing exposures, decreasing vulnerabilities, and preventing unequal consequences. And that's really what we're trying to look at in terms of our social context, our interventions, and frankly, also we need to think about in the policy context. In terms of racial and ethnic disparities in behavioral health specifically, we definitely need to really look at culturally appropriate care, barriers, overcoming barriers, immigration policies, destructive healthcare system, all kinds of historical traumas and structural inequities and systemic racism that we see even within our healthcare institutions, and really trying to address inadequate support for mental health services and safety net settings, which the general is, and to do this work that really is needed to be done with the community. And this is a photo or an art piece that maybe some of you have seen in other places by Elise Ruriani, who's a expressive art therapist and artist. And this is a depiction that she has. If we really want to address mental health, we need to dig deeper, past just the medical models and individualism and pathologizing communities, but really looking at the deeper areas of injustice, trauma, inequality, violence. So those are some of the things that we need to think about digging deeper. And then we know for children, which Dr. Tolou-Shams will be talking a bit about, is in addressing these disparities in COVID-19, we really needed to do a rapid implementation of telehealth. There was disparities in that access, high levels of teacher and parental stress, disproportionate educational disruption, especially for kids with special educational needs, or who didn't have enough supports in their home to be able to have enough academic instruction, potential for elevated trauma exposure under those stress and abuse, and compounding of already existing trauma and disparities with losses in their community. So I turn to Marina Tolou-Shams.
Hi, good morning. Thank you, Lisa. I am going to talk about some of the challenges for institutions and system-involved youth, and then some of our current kind of community capacity building and care navigation projects that are happening here to begin to address some of these significant challenges and issues that Dr. Fortuna just discussed. Before I talk about, I just want to explain this Aboriginal art painting that is on here that I actually took from my own home. And in Aboriginal mythology, the rainbow serpent actually represents, it's an immortal being in Aboriginal mythology, and it's said to be the giver of life due to its connection to water. However, it can be a destructive force if enraged. And so I thought that this, outside of being just beautiful piece of art and colorful, it represented a lot of what we're talking about here, which is addressing these issues to give life to those who have been so underserved and historically marginalized, particularly in relation to addressing the trauma, the chronic trauma and exposure that has been there for a long time and being greatly exacerbated and elevated through COVID. And so you'll see on this list, when I'm talking about institutions for children, I'm talking about group homes, detention centers, residential substance use treatment placements, foster care home placements. And you'll notice on this list, it's almost identical to the prior slide when we're talking more generally about children in the community and schools, but with the exception of the rapid implementation of telehealth and a remote educational programming. In fact, it's largely been the opposite for institution and system involved youth. In fact, very few of these placements and detention centers even are allowing the necessary resources or access to the technology that's needed even to address family separation and high levels of parental stress and being separated from your youth, not even having the opportunity to have face-to-face visits, and then not even being able to use technology to assist with that. So here in San Francisco, in the Juvenile Guidance Center, for example, there is one desktop computer that youth are using to be actually in video contact with their families and now attorneys, but there is no mental health intervention that is being delivered through those services in addition to, for the families, in addition to what's being offered through the SPY clinic. So we have some disparities upon disparities here for institutionalized youth and system-involved youth, and really disproportionate educational disruption. Isolation due to COVID-19 is disrupting education in these placements, and a lack of staffing to maintain the type of educational structure that needs to occur. And then I already spoke about the elevated trauma exposure and the compounding of existing trauma and disparities for this population. So next slide, please. So some of the pieces that we brought up in the commentary as examples of ways to partner with the community and to do some community capacity building around access to mental health services for our most underserved youth in who are system involved, have focused on developing what has been named by the collaborators, the Youth Justice and Family Wellbeing Collaborative. And what that collaborative is, and we just had our third meeting yesterday, it is a group of about 15 core members of the systems who are serving these youth and are responsible for connecting them with behavioral health services. So juvenile judges, attorneys, child welfare, human services agency partners, Department of Public Health, behavioral health service providers, San Francisco Unified School District, community-based organizations serving diversion youth. Who am I forgetting here? I'm thinking here. Behavioral health services, juvenile probation, of course, at the table as well. And what we have done is basically taken these 3 different projects that have been funded through different means. And I'm not going to go into detail into each of these today, but And the Family Telehealth Project, I do want to acknowledge the Visa Foundation for also funding, which I realized was not on the first slide. But each of these projects is using technology in some way to leverage access to mental health and or substance use prevention interventions for justice-involved youth in the community and foster care youth who are in out-of-home placement. And this collaborative really organically formed as a function of the need to build the community partnership to understand how, as systems, we move the systems to incorporate and leverage technology within the systems. And then COVID hit. And so now we're meeting monthly to figure out how to move the systems organizationally to integrate the use of technology for linkage to services. And it's a challenging prospect, particularly in the height of all of the system affronts that are happening. But it is a unique opportunity for us to be thinking about how we leverage resources and build efficiencies using technology to increase access for our families. And then the other piece is a telehealth learning systems hub. So we are, we're suggesting that we think about how we can provide a learning systems hub in which the community can access to get supports about how to build the telehealth behavioral health service structure within their own community-based organizations. So we talked about in the commentary that this was something that the field should be really thinking about in ways of supporting and partnering with our community providers. And we are currently interviewing and partnering with at least 4 CBOs right now who are providing child behavioral health services through DPH because they really want to understand how we can work together to serve these youth. Next slide, please. So in the commentary, we also talk about care navigation. And this is an example of something that we're doing here. So care navigators have come out of the cancer literature. They've shown remarkable evidence for improving health outcomes for cancer patients, for underserved, publicly insured or uninsured patients. And yet there are very few, if any, empirically supported navigator models for child mental health. There are some navigator models out there for youth with autism spectrum disorder and developmental delays, but there have been so few models focused on mental health service care coordination for our most vulnerable youth and families that NIMH put out a specific program announcement to develop and test family-based navigator models. And Dr. Fortuna and colleagues actually have one of these grants as well that they are working with pediatrics in Boston. And so we really spoke in the commentary about how to address the overwhelming disparities in care access, retention, and mental health outcomes, that this might be one way that we should really be thinking about, and that there's no empirically supported or tested model for youth who are system involved either, such as those in foster care and juvenile justice, or those seen for medical care in a safety net hospital setting like ZSFG. So this is an example of what we are thinking about for both pediatrics at ZSFG and actively testing and developing with our community mental health partners, CBOs that the youth may get referred to from pediatrics, as well as our pediatric colleagues, and many are involved in this effort. And you can see at the bottom of the slide that this Family Mental Health Navigator Interagency Collaborative, we really are recommending to the field that the model development and working with youth and families directly and working with those with lived experience who are all going to be inputting their feedback to this model must occur as well with a collaborative example like I spoke to you about before, which is the community and academic and systems partnership to look at the broader systems and organizational level factors in order for this to actually be implementable and sustainable. Slide. So I just wanted to show you, this is an example of how the navigator model is being built and how we talk about in the commentary that really what is needed for the field in order to reduce these inequities and health disparities is a systematic way for families to go through these steps in the cascade of care, starting at screening to assessment, identifying those who are in need, to referral, initiating treatment, and then following them through retention, engagement, and continuing care. The navigator following through all of these steps, so not just linkage, where we know families often drop off, not because of the families, but because of the systems and the lack of care coordination across the systems, that we need to develop models that are going to address this entire cascade of care and provide navigator supports across this entire cascade of care. So this is, something that we need to be thinking about because, for example, if we don't have systematic processes for identifying who is in need of treatment, we inadvertently perpetuate inequities when we think that we have an idea of who is more in need than one person more in need of another, or we don't have a systematic way of triaging or identifying who's maybe highest need and thinking about efficiency of resources to address those who are highest in need. So this is an example of what we're building here, and we think is a forward direction for the field. And then the last thing I'll say, and that this is directly taken from the commentaries, that healthcare regulations and reimbursement strategies should help structure collaborative care and prevention strategies across sectors, taking advantage of technological advances that can support these cross-sector partnerships. And this is really the larger policy organizational piece that Dr. Fortuna also referred to earlier that is key and part and parcel of this work. And that's why I presented to you about this community and academic collaborative and systems collaborative piece that really has to be part and parcel of the direct youth and family intervention services and delivery. Otherwise, we're not going to be able to really, at a much larger policy systems level, dramatically impact all of these disparities that you just heard about at the beginning of this talk.
Thank you, and good morning. So even as we begin to contain and treat patients for COVID and begin to do more around preventing the spread of the virus, we're going to be really increasing our efforts on responding to the mental health impact of shelter in place, of the economic hardship of 1 in 10 unemployed, more that are underemployed, fear of infection, especially for essential workers in the service industry and the healthcare industry, the long-term impact of the illness, and the mourning of loved ones that we can't even do the way we used to. So with all this work to do, and even with the very impressive initiatives that Dr. Tolou-Shams described here at UCSF, one of the things we want to think about is that for the field, not fully understanding disparities has led to some mistaken assumptions about how we can address and increase our reach. So there's been a big push for increased healthcare access and insurance coverage. And even with the Affordable Care Act, there are many in this country who do not have coverage or do not have adequate coverage. And, we have to ask ourselves, why is there such a push to dismantle this program? And why is there so much disinformation about it and really about healthcare in general? Coverage is absolutely necessary, but it's not sufficient to reduce disparities. So even increasing insurance coverage will not ensure that we will increase providers in Black and Latinx neighborhoods. It's not going to eliminate stigma associated with seeking treatment, nor eliminate the mistrust of providers. and it will not ensure that providers will have cultural competence or cultural humility. So these are things we still have to address. Next. So we know that there are a lot of very good evidence-based interventions for anxiety, depression, ADHD, substance abuse disorders, and so on that are readily available and do work in diverse populations. I think we have a question about, do we create a specific intervention for a specific group, or do we do some adaptation so that it's more accessible, satisfactory across groups? So that's something we need to do, but there's limited investigations of cultural nuance and how to best tailor EBTs. So the ones that overcome obstacle to care depend on increased engagement and outreach in the community. And, even to the use of mobile interventions, and that might be mobile units and vans, but also thinking of mobile apps and the internet. Current service planning should address minoritized preferences, patients' preferences for care, both in face-to-face treatment and in the growing use of telemedicine. We, are experiencing now and I'll talk about it a little bit more in the study we're doing, but we have providers with high-speed internet access and patients with very slow, glitchy connections, and that doesn't make for good service. We want to make sure that there's financial support of integrated models and capacity building of lay paraprofessionals and community health workers. You just saw explanation and description of the Navigator program that's really important and effective. We want to think about workforce and community partnerships that desegregate care and the workforce. Next. So again, going back to CBT as an example of a widely used evidence-based treatment that can successfully address a number of different disorders. But we need to do more than just pull it off the shelf if we're using it for patients across different cultural and linguistic backgrounds. So we want to think about ways of tailoring care that increases reach for these evidence-based treatments. And that includes translation. So they're available across languages. And we want to think about adaptation or enhancement of manuals and materials that can be shared with patients. And these adaptations should really reflect attention to within group variation, language, culture, age, and so on. And especially now as patients and providers are becoming more expert in telemedicine, it's more urgent to promote innovative services that respond to patient needs and preferences. And here's where technology can play a big role, and we should further explore ways to support its use. So even while staying true to manualized EBTs, we want to allow flexibility and adaptability in evidence-based practice. And I'll just talk a little bit about an example in the next slide for the study that we're doing with Dr. Fortuna. So this study is Kids Face Fears, and it's a translation of a proprietary suite of online and face-to-face anxiety treatment for children and adolescents. So anxiety affects over 4 million children in the US, and we really need to increase our reach, and especially in light of this pandemic, which has really shot up everyone's anxiety. So we've been working with a national team to conduct a patient-centered pragmatic trial of this evidence-based anxiety treatment. The RCT is designed to test the comparative effectiveness of face-to-face, which now means not just face-to-face in a clinic, but face-to-face over Zoom, compared to an online asynchronous care through the use of a self-directed computer program, along with maybe a parent coach, some adult coach that works with the child. This program that was developed and tested in Australia. This is a country that's 85% white, primarily English speaking. And we're trying to roll it out in 4 regions of the United States. So Seattle, Boston, Baltimore, Miami, with a diverse population. And we needed to translate it to US English. So it's not as if people are getting anxiety treatment from Crocodile Dundee, but, to really make it more relatable to patients here, and also to translate it into Spanish. And given the number of Spanish ethnicities in the US and variation in Spanish language between ethnicities, translation was actually very complicated. We spent weeks getting feedback in translating key terms such as, what's the right way to describe the coach who will be working with the child? What are common terms like stepladders and thinking about exposure? How do we talk about bullying, or do we not translate it because it's commonly understood? So it was important to really think about clinically informed translation for these psychoeducational portions of the treatment. One thing that's really attracted me to this study and this mechanism is that PCORI requires patient and parent family stakeholders and parent or patient co-investigators. So that really reinforces this emphasis on a patient-centered approach. We meet with stakeholders quarterly. It's a lot of work, I have to say, because it's not the paradigm we have where researchers decide what to do and carry out their research, but it's really a collaborative effort to do the best work in answering our research questions and providing the best experience for participants and patients. So our stakeholder group has given us a lot of guidance on adaptation, now within limits because we can't change this proprietary intervention. But they've helped us with interpretation, ideas for recruitment, implementation, including data collection and engagement with families. Some of these examples have included the development of a technical orientation for families who are randomized to the online computer program. Some other examples are Latino parents strongly encouraged us to rethink how we present treatment options for adolescents in the study. The program designed in Australia is really probably was designed for more affluent white population that emphasizes the option of teens working on their own more independently without the need of a parent coach. But our Latino parents really countered with the need for parents to be more involved and to work more closely with their children. And they really had to, they mention this consistently through our meetings. So, we really take that to heart in thinking about how we present this program to families. One example, we see is a conflicting understanding of social anxiety. So the manual emphasizes the need to look an adult in the eye for this exposure practice as part of the treatment. But we also want to make room for an expanded conception of ways to overcome anxiety that don't require looking an adult in the eye. If that is culturally understood as being disrespectful, or if it would unnecessarily heighten distress for a child with neurodiversity. So there's just some points where we can do a little bit of tailoring within the confines of using this manualized treatment. And finally, we've done a lot of work with our stakeholders to come up with strategies to address technology barriers, where households have limited computer and internet resources, especially now as they're being so used by remote learning during the shelter in place. And so we have to seriously consider the benefits of simply using a phone for treatment if slow internet connection makes audio conferencing too difficult. So, thank you.
Unmuting myself. So, so thank you. So now I'm just going to think of all of these things that we're talking about in the context, because, you know, upon COVID, you know, on top of, I guess, COVID-19, as we know, we have experienced this added awareness of racism in our country, and violent deaths to people of color that we've witnessed on TV, but things that have been chronically occurring in our communities. And so one of the things that people may not be as aware of is that, you know, the Black Lives Matter movement has always also thought about Black mental health has to matter too. And there's always been this underpinning of thinking about these violence and injustices that really do impact on the mental health of communities of color. And we can see this quote here from a attendee on a program called Stories Against Stigma, where this attendee, Carla, says, "Our kids are losing people every day. We are just constantly seeing death." And really thinking about the sort of pervasive trauma, right, that people are experiencing on top of, combined with these disparities that we're trying to address. So for that reason, really what we're needing to think about is principles of trauma-informed approaches to all of these interventions and things that you've heard about even in the interventions that we're talking about. We're trying to employ a sense of safety for communities, and these are the 6 key principles of trauma-informed approach to anything that we're trying to intervene on, is that we're really employing safety, trustworthiness, and transparency in the work that we're doing together, that we're thinking about how to use peer support, and in some ways of navigators, and some of the things that we're adding to the intervention of coaches. It's really around having a peer that's there with you, that understands your circumstances, or at least can, you know, walk with you through those circumstances. Collaboration and mutuality in the work that we do with individuals, as well as systems and patients and communities that we're working with. That there is this idea of empowerment, voice, and choice in the things that we're doing, and that we're taking into context cultural, historical, and gender issues that do have an impact on experiences of trauma and how we experience it in institutions and one another. And so the importance of taking that into consideration in any of these interventions that we're engaging with the community. And then I'm just sort of bringing it back again to this article from Pediatrics, because, you know, we've heard a little bit about some interventions and things that we think we can do. And it's really at the, you know, that's really represented in the middle there, the middle half circle, where we're looking at medical care and personal behavior. But what we're talking about too is the importance of really looking at also community level factors that we're trying to interact with and work with the community in impacting. You know, how people's living and working conditions. Dr. Tolou-Shams' situation, where she was talking about youth who are institutionalized, right, or in foster care, or, you know, or in these particular situations. And then also we need to think about the economic, social opportunities and resources that need to be employed to be able to make a real difference on how we can shape disparities in health, which is foundational. So on top of the interventions that we're doing, I think where the field is moving is we really have to think about how do we impact policies to promote child and youth development and education from infancy through college, right? How do we have an impact on how institutions are funded, or how things are supported, or how do we think about child protection services or school systems? I mean, all of these things have to be taken into account. Policies to promote economic development and reduce poverty, right? Because that's really at the core of health and health disparities. And then policies to promote healthier homes, neighborhood schools, and workplaces. So on top of, at our medical care and addressing personal behaviors, we really have to think about these greater societal and policy impacts that our interventions and our advocacy, to be honest, needs to address as well. And I also wanted to make sure that we included issues about the workforce. So, we've talked about, in Dr. Tolou-Shams, these navigators, people working in the community, even with our PCORI, talking about, we have different providers who are working in communities that are very affected by trauma and stress. And I think also we see this at the general, for sure. But we really have to think about these things in our workforce considerations. How do we transform our educational and clinical environments to be inclusive? UCSF even, right? Culturally responsive, trauma-informed, and safe for people of color and the disenfranchised. And that's what we have to think about at an institutional level. And the safety means that it's possible for individuals to talk about the predicaments they face and to call out injustices without fear of reprisal. And that's how we treat our patients and our staff and our faculty. Take into consideration the burdens on trainees, staff, and providers of color who are working within very disenfranchised and stressed communities. There is a real risk for the development of vicarious trauma. And so we have to work very carefully and thinking about self-care and rest and not re-traumatizing people by causing disrespect or harm to even those people who are working within those communities. And one way to do that is through our cultural humility, being other-oriented, respectful of cultures associated, and understanding that those cultures can be associated with improvement in therapy. I mean, as we saw in some of the things that Dr. Porche was talking about in terms of really trying to have that culture of humility lens to be able to understand how people can really interact with the interventions that we're trying to utilize to be able to support people. That's really important. And as of late, we have been working with the Latino community in the mission in trying to work on some of the interventions, thinking about cultural humility. And some of the things that they said is, we want to have these talks where we talk about mental health and overcome stigma. And so we started to have this series called, to ask the doctor, preguntar al doctor. And one of the things that became very clear is that they want to hear like our expertise, but they want to be able to express like their own understanding of healing. And one of the themes that has come up is la cultura cura, culture cures, right? How do we sort of lean into our culture and our understandings and our own understanding of how to heal in community, and how does that interact with Western medicine concepts of, say, CBT even, or, but from a collectivist, or, how do I do that in thinking of spirituality and how I think about things. So it's been a really interesting interaction of people's own understanding culturally, along with our own understanding of depression or anxiety or PTSD. And then finally, we saw, we're seeing in COVID-19 really just exacerbated and revealed really how structural barriers are a real impact negatively on people's mental health and health. And one of the things that's been said is that the coronavirus may be agnostic. It's going to try to hit whoever, right? but the health consequences of structural racism and inequities are not. And therefore, we could definitely see the disproportionate impact. So we need to promote and support the expansion of a diverse behavioral health workforce to deal with this next wave of pandemic of mental health consequences of COVID-19 and with everything else that's happening right now. We really need to resist, and I really sort of want to underline this, resist pathologizing the distress that communities are experiencing that are really stemming from injustices and human rights violations. And to respond to the combined effects of COVID-19 and systemic racism, we really have to commit to working to eliminate health disparities through the social justice lens. Otherwise, you know, we'll be in the status quo right past this pandemic, and that's not where we want to be. So Juneteenth, June 19, you know, we're hoping to have some celebration for that and more to come around that, but just wanted to share that. So I'm going to stop sharing and see any questions. All right, so one of the things that they've said, people have said, is would it be possible to get the link to the commentary? And I can work on sending that out. And then here's one question. The Australian study is very interesting. Do you have any preliminary findings about its effectiveness? Dr. Porche. You want to take it?
Yeah, we were just really starting to recruit patients for the study, and COVID hit. So we're on pause right now, but I think early indicators of our, 30 plus patients show that the symptoms are reducing in the way we would like them to. We have families who say that they really like the online treatment, and families who really like the face-to-face and have really adapted very quickly to doing face-to-face over Zoom as they finish out treatment that started before COVID hit. So it looks promising. I have to, I have thoughts about, where there might be some snags in people using the online, but so far it looks promising.
Right. The interesting thing about that study, it's supposed to be 1,856 patients. It's a very large pragmatic trial, and we'll definitely be able to see something. And I agree, it'll be really interesting to see how, if we can do the telehealth face-to-face version, how that really impacts on people. Really, some of the things that I think we've seen even clinically is that the telehealth has improved show rates, right? Improved access in many ways if we can get the technology to work.
Yeah.
One of the things that Nick let me know is that someone said if we could send the slides, and we can, if my co-presenters are okay with sending slides out, and we can send a commentary link as well with that to everyone registered. Any other questions? I don't see any other questions in the, oh wait. Okay, here's a question. So I think it's from Joyce Dorado. This has been a great grand rounds. One thing I was wondering about is how we can look at the importance of including the naming of the trauma-inducing effects of structural racism as part of psychotherapy interventions. And addressing these effects directly. I think that's a very good question. I'll see if Dr. Tolou-Shams has some ideas about that too. Some of the things that I've started to do, and it's not so much in this Australian intervention, obviously, because it's more of a standardized intervention that I can't fidget too much with. But in other studies where I've been able to look at the CBT constructs, right, and I have come up, I've directly asked people about youth, about experiences of discrimination, or where they have felt disrespected because of who they are in terms of race or ethnicity, and anything that has impacted them in that regard, and sort of in a very open way. I've listed things in terms of, sort of trauma, not necessarily calling it trauma, but calling it, even though I think it is related to trauma, sort of almost the way the ACEs look at things, right, in terms of adverse childhood events, and include experiences around immigration, discrimination, disparities, racist experiences, and just call it that, right, in terms of adverse experiences that we can have, and have conversations with kids of sort of situations where that might have impacted them, how that made them think or feel from a CBT model, right? And then how are they looking at that now, right? In sort of a more narrative kind of experience of how they're framing that in their lives and how it's impacting on them. So, and then also the idea of separating what is their experience versus what is really institutional and structural, right? And how do we look at the structures that impact on our lives, and how do we address those? So I don't know if Marina has any.
So the only thing I will add, and this is not directly in a psychotherapy context, but it's in talking with youth and young adults right now, is that it is just coming up in the conversation, and it's being named, and it's our responsibility, I feel like, to name it with the individual, the youth. I mean, I'm very like adolescent focused in the work that I do. So I'm thinking about the teenagers, and to give voice to that, to amplify it. And so I've been following their lead in how they name it.
Mm-hmm. Yeah. And it comes up a lot, I would agree, at least in the populations. Again, if you build that trust of being able to sort of talk about those conversations.
I was just going to say too, sorry, that I do think it raises the question of how, as researchers, we're measuring this.
Yes.
And I just want to put that out there. I think that's a whole area that is very understudied, and that we need to be thinking about as researchers. So I'll just leave it at that.
Absolutely. Are there any efforts at UCSF to improve access to mental health services for patients who have Medi-Cal? And I know we see them at the General. I don't know if there's any bigger efforts, Matt.
Sure. So the Medi-Cal question at Langley Porter Hospital and Clinics is a complicated one, only because it differs for inpatient versus outpatient. The inpatient, there has been no progress, but there hasn't been for any freestanding IMD, Institution for Mental Disorders. It's a federal law that prevents us from billing for Medi-Cal. We still take patients with Medi-Cal from the emergency room when we cannot, find another appropriate placement for them. But it's a huge problem across the state. It's been, we've advocated at the level of governor to try to get this changed, but in fact, it's federal law and a serious, complicated issue. With regard to outpatient, we anticipate that when we move to funds flow, which is part of the UCSF Health financial system, that'll be coincident with our move into the new building down in Dogpatch, that will open the doors to outpatient Medi-Cal across a lifespan for us in that building. So that's the answer. So the answer is yes for outpatient. Unfortunately, no progress for inpatient at this point.
Okay. And then just a real quick question, because I know we're at the end here, but there's a question about how do we cope with feelings of overwhelm and hopelessness when wading into such complicated systems? And I would say working collaboratively with the community, and knowing that we're in it together. I think is a really helpful thing. And I think working with young people and seeing their hopefulness, right, in trying to persist and move forward, and how we can make a difference together. I mean, I think that's what helps me. And then I would just add to sort of what Marina said in terms of, you know, how to deal with these issues of just talking about racism and, you know, and all of that. One of the things I have found is kids do bring it up. I agree. We can ask about it. I think validating that and listening is the most powerful thing. And sometimes that's all that's a really powerful thing, for have someone to listen to you, to be able to, for you to be able to express it and to validate that it's real. If they're not nuts for thinking about it this way or experience it this way. And building the relationship. So I think that's the way that we really address those things under very difficult circumstances. But yes, how do we continue to measure it and intervene? So I think it's 9:31, and I think we got to most of the questions. Thank you, everybody, for participating today in the Grand Rounds.